Time is brain. From that very first drooping face to the last salvageable neuron, a clock is running, and you're it. Welcome to this explainer on ischemic stroke. We're breaking down one of the absolute most tested med-surg diseases on the NCLEX. We'll build this out step by step so you'll know exactly how to recognize, diagnose, and intervene when literally every single second counts.
Okay, so let's dive right in. When we say time is brain, we mean an ischemic stroke is basically a brain attack. A clot, maybe a local thrombus or a traveling embolus, often from atrial fibrillation, completely blocks a cerebral artery, and bam, blood flow stops, and the brain tissue starts starving for oxygen. Every single minute that artery stays blocked, you're losing about 2 million neurons. That's right, 2 million a minute. This is why it's the ultimate medical race against the clock.
Now, the brain doesn't just lose a whole section instantly. It's more like a bullseye. The dead ischemic core right at the center, that dies very quickly, and unfortunately it's permanent. But surrounding that core is the penumbra. Think of the penumbra as this critical zone of at-risk, dying neurons. They're struggling, but they aren't dead yet. The whole entire game in acute stroke management is saving that penumbra. We can totally rescue it if we just restore blood flow fast enough.
So how does this actually play out? Let's trace the pathophysiology step by step. First, the artery blocks. An embolus or a thrombus wedges tight inside a cerebral artery. Second, downstream blood flow abruptly stops, completely cutting off oxygen and glucose. Third, we hit cellular ischemia. The neurons basically run out of gas. They shut down, and clinical deficits pop up out of nowhere. And finally, step 4, that penumbra window opens. That surrounding tissue is literally crying out for oxygen, and it's on us to get it back before permanent infarction sets in.
To recognize this instantly and actually save that penumbra, you've got to memorize B fast. Burn this into your brain for the NCLEX. B is for sudden balance loss. E is for eyes, meaning sudden vision changes like hemianopia. F is for face drooping, usually just on one side. A is for arm weakness, again sudden and unilateral. S is for speech difficulty, like slurred speech or aphasia. And crucially, T is for time. You must always, absolutely always, note the last known well time. The hallmark here is a sudden onset of a focal deficit. If you see it, boom, activate the stroke protocol. Okay, walk out, because here's a classic NCLEX trap. The test writers absolutely love checking if you know your hemisphere clues. If the stroke happens in the left brain, you're going to see language issues like aphasia paired with right-sided weakness, and the patient is usually slow and cautious. But if the stroke hits the right brain, you're going to see left-sided weakness paired with neglect, and the patient will often be super impulsive. Just remember, left equals language. Lock that in.
All right, so you suspect a stroke. What is the absolute first test you run? It's a stat non-contrast CT of the head. This is your #1 priority. Why? Because you have to definitively distinguish an ischemic stroke, which is caused by a clot, from a hemorrhagic stroke, which is caused by bleeding.
Let's test this out with a quick NCLEX moment. A client arrives with sudden right-sided weakness and slurred speech starting 90 minutes ago. What test do we need before thrombolytics? You've got 3 seconds to drop your answer in the comments. 3, 2, 1. And the answer is C. A non-contrast CT must confirm the stroke is ischemic and not hemorrhagic before you even think about giving tPA. Giving a massive clot buster during a brain bleed? Yeah, that would be completely catastrophic. It's a massive NCLEX trap, so never forget it. Always CT first. Now, if the CT comes back crystal clear of any hemorrhage, you enter the strict tPA window. You only have 3 to 4.5 hours from that last known well time to safely administer alteplase, or tPA, to dissolve that clot and save the penumbra. That narrow window right there. That's exactly why noting the time was the T in B fast. But hold on, be extremely careful here. Even if you're perfectly inside that 3 to 4.5 hour window, you have to run down a strict checklist. Why? Because bleeding is the ultimate danger. You absolutely cannot give tPA if there are any contraindications. We're talking recent surgery, any active bleeding, a history of hemorrhagic stroke, or abnormal labs like low platelets. Any of those rule out tPA entirely. Safety is always your #1 nursing priority. Let's map out your priority nursing interventions sequentially right down the line. #1, protect the airway and get that stat non-contrast CT to rule out a bleed. #2, administer tPA to dissolve the clot, assuming they're eligible and in the window. #3, keep the patient NPO until they pass a swallow screen. Number 4, maintain permissive hypertension, which we'll break down in just a second. And number 5, prep for a mechanical thrombectomy if they have a large vessel occlusion, which physically retrieves the clot and extends our treatment window.
Actually, I want to really focus in on step 3 for a second. After that acute clot phase is managed, aspiration becomes the silent killer on the stroke unit. Because of this, you must keep the patient strictly NPO until a swallow screen is passed. Strokes heavily impair the gag and cough reflexes, so that means no food, no water, and no oral meds until they are officially cleared. Period.
Let's hit another NCLEX question to really lock this in. After an ischemic stroke, before offering oral fluids, what must the nurse do first? Read the choices and drop your answer. 3, 2, 1.
The correct choice is B. Stroke frequently and heavily impairs swallowing. Performing this simple dysphagia screen is literally the only way to prevent deadly aspiration pneumonia. Absolutely nothing goes in by mouth until swallowing is verified as safe. It's a super common test question because it's a critical real-world safety measure.
All right, let's briefly touch on hemodynamics. Do not aggressively drop their blood pressure. We actually want what's called permissive hypertension. The brain desperately needs higher perfusion pressure to force blood into that starving penumbra to keep it alive. So we let it run a little high, unless it spikes over 185/110. If it crosses that strict threshold, it's a massive red flag and actually disqualifies them from getting tPA because the pressure is just too high and could cause catastrophic bleeding.
Wow, okay, we've covered a lot. The pathophysiology, those sudden BFAST symptoms, and your absolute priorities of care. To sum it all up for the NCLEX, just remember this one simple memory hook. CT first, then tPA, and keep them NPO until they can swallow. If this made it click for you, subscribe. We'll be bringing you one killer med-surg topic every single day until you pass the NCLEX.